I'd like to thank Mary Lynch and her team for inviting me here to speak this afternoon. Can everyone hear me? Okay, so I'm going to talk about the role of advanced nurse practitioner in heart failure and palliative care here in the Mater Hospital. So, overview of the presentation. So I'm going to go briefly over the heart failure service here in the Mater and the purpose of the advanced practice post, and ultimate, very, very important collaboration with the multidisciplinary team, and the principal duties and responsibilities of an advanced nurse practitioner, a definition of palliative care, treatment options, and societal costs of heart failure. So the definition of advanced practice as in agreement with NMBI, this is the one they've approved, is advanced practice has been defined as a continuum along with which practitioners develop their professional knowledge, clinical reasoning, clinical judgment, skills and behaviours to higher levels of capability that is recognisable. And this is the Nursing and Midwifery Board of Australia 2014. So the Mater Heart Failure Service was set up in 2003, and very much the involvement with the multidisciplinary team is paramount, and it facilitates inpatient, outpatient service. We're also a national referral centre for patients with advanced heart failure for assessment of heart transplant, and also the National Heart and Lung Transplant Unit opened here in 2003. So the purpose of the post, the overall purpose of the post is to provide expert nursing service designed to optimise patient care and improve the quality, safety and timeliness of acute chronic heart failure management provided to patients here at the Mater Hospital. Advanced practice will include conducting comprehensive assessments, formulating differential or tentative diagnosis, formulating treatment strategies and implementing these treatments. The registered advanced nurse practitioner will combine skills and knowledge on a range of social, biological, psychological variables in the provision of a holistic patient care. I know this looks very busy and I'll just scan a couple of them. So the principal duties really, autonomy and expertise in clinical practice, relates to professional accountability, professional and clinical leadership, responsibilities to provide professional clinical leadership, strategic direction, expert advice and support to the clinical team, and working in partnership with our nursing, medical and allied health professionals. And research, the RNP in heart failure will conduct research, publish nursing research which shapes an advanced nursing practice, education, the wider policy and patient safety agenda. And we've also developed links with our clinical partners, Professor Lazarina O'Connor, who's Joint Professor of Clinical Nursing at UCD, the Mater Hospital and Vincent's Hospital. So the principal duties and responsibilities of advanced practice posts is to provide a safe, efficient and effective service in accordance with the Mater Hospital ethos, vision and mission statement, and to maintain the highest standards of care to all patients in accordance with principles of best practice, and by providing timely, cost-effective care, promoting wellness, patient safety and quality of care, an individualised holistic approach to patient care using core competency to achieve these positive outcomes. So translating this into clinical practice, and to me this is the most important slide in this whole presentation. Every patient encounter is unique. Advanced practice acknowledges this individual uniqueness and considers the physical, psychological, social, emotional and spiritual determinants of health or ill health. And patients with heart failure need to be empowered towards self-management of their illness. And the major goal really is to facilitate a holistic approach to the care of each patient. The assessment, diagnosis, treatment and health education component of the role is central to the provision of the high standard of care. And this incorporates the multidisciplinary team approach, which is essential. And the definition of palliative care, as defined by the World Health Organization, is to improve the quality of life of patients with life-limiting illness, and this can be applied to all chronic illness, COPD, dementia, and this was won at the World Health Organization in 2016. And management of physical symptoms, psychological, social and spiritual problems are paramount, and the goal of palliative care is the achievement of the best possible quality of life for patients and their families. Integrating palliative care into heart failure. So in the UK, they looked at the National Service Framework, highlighted the need for the palliative care approach and access to specialist palliative care physicians for patients with end-stage heart failure. And the European Society of Cardiology published a consensus statement on palliative care for patients with heart failure. And now more recently, the European Society of Cardiology guidelines for the diagnosis and treatment of acute and chronic heart failure 2016 really highlighted the importance of integrating, as we've heard throughout today, integrating palliative care at an earlier stage. And also they focused on looking at frailty in heart failure patients and also ensuring that patients were referred on to rehab programs, and that had significant benefits. So our experience, I mean, we've heard quite a lot this morning about the Palliative Care for All, integrating palliative care into disease management frameworks, and also the report recommended an action research project, which Karen's already discussed this morning. And from some of the benefits for us were linking in with the hospice, acquiring hospice beds. But going back, one of the main difficulties really with heart failure patients is the disease trajectory is so difficult to define. These patients can be clinically stable for months, years, and then suddenly decline, and also can make a remarkable recovery. I mean, even some of them, I know Karen's seen patients with myself in the past, and that's the beauty, like palliative care can step in, they can also step back, you know, when a patient improves. So I think that's really important, as it's never too late or it's never too early to bring in palliative care, and having the option of them stepping back has to be acknowledged. So as I said, sometimes the patients respond very, very well, and sometimes we see patients and they have increased readmissions. So the common disabling symptoms, which we've heard a lot about today, the breathlessness, the fatigue, the anxiety, pain, decreased exercise intolerance, decline in functional capacity, anorexia, constipation, those are all of the major symptom burden for this group. So advances in care, we've certainly developed an excellent collaborative practice with the palliative care team here, and we've already heard about the therapeutic breathless clinic and also having access to hospice beds. So communication, and I know that's been emphasised throughout the day, and it's so important. Little experience, like within cardiology, there's very little experience in exploring patients' concerns and wishes. The main focus really is on treatment options. I think trying to cure patients when we know that's not an option, and really we should be listening to patients' concerns and wishes, and ideally maintaining hope and realistic goals while telling the truth. And coordination of care, as I said, is difficult on occasions for those revolving door admissions. And these are the patients that we come in, they're clinically stable for, as I said, they could be in hospital for like 10, 11 days, it could be on inotropes. And we'd have had discussions of end-of-life care, you know, what are their preferences, and then suddenly they make a remarkable recovery. And I know a lot of my colleagues here in the audience who work in heart failure would have certainly seen that. Communication skills, I cannot emphasise the importance of that throughout. Aside from symptom control, effective communication is vital in empowering patients to make life choices and aid in improving quality of life. And experiential training, communication skills, I know happens within oncology teams, but it has demonstrated improved collaborative care, shared decision making, and improved patient experience. So the psychological symptoms, there's an increased prevalence of depression in heart failure patients compared with the general population, and this group are likely to be admitted to hospital to die. Depression affects the patient's ability to make decisions, understand his medication, resulting in poor compliance. Non-pharmacological management, exercise and cognitive behavioural therapy programs, if they're available. Antidepressant medications such as SSRIs inhibitors appear to be safe, and anxiety is extremely common. We are fortunate now to say that we've got a psychologist available for inpatient and outpatient support, particularly for the patients who are here with advanced heart failure patients, so patients who may be in the coronary care unit here and who are on intra-aortic balloon pump, inotropes, and are waiting for a transplant. And the psychologist has been an absolute excellent addition to our service. So advanced planning, sensitive exploration of both patients' and carers' wishes about their care with regards to place of death should take place. And planning may include discussions about resuscitation, and this should be communicated between healthcare settings. Likewise, arrangements should be made to reprogram ICD device to pacemaker mode to prevent the risk of distressing, potentially repeated, clear conscious shocks in the dying phase. And I know Professor Jim O'Neill has discussed that at great length with all of us earlier on today. And the last few days, it should be considered furosemide infusion subcut if required. Breathlessness may require opiates such as morphine and benzodiazepines such as midazolam by subcut infusion and titrated depending on previous 24-hour usage. And as I said, we've developed a very close liaison with the specialist palliative care team, and they're always on hand to advise us. And the societal costs, that was briefly mentioned earlier today, it costs $660 million each year. And there are over 90,000 people in Ireland suffering from heart failure, and another 160,000 people living with impending heart failure. And the hospital-related costs are 47% of the total direct cost of heart failure, and this is a significant toll on hospital bed days. And the national total annual bed day for heart failure comes to 231,042, and the national average length of stay is 11 days. And the other important point to remember is a lot of our patients, we've heard it throughout today, are elderly, they're frail, they've got multiple comorbidities. So, okay, patients are living longer, we're seeing them coming more and more into hospital, their length of stay can be longer than 11 days. Again, it's because of the multiple comorbidities that this patient population have. So in conclusion, specialist palliative care teams can help with education, support and management of complex and persistent problems. The difficulty in prognosis makes this challenging, and development of links between cardiology, palliative care and primary care must continue with mutual learning and understanding, contributing to better patient-centred care. And the end-of-life care strategy was released by the NHS in 2010, and this is a useful document to help guide us with end-of-life care.